Good morning, everyone. I'm Kristen Ganjoo from Stanford University, and it's a pleasure to be able to present to you guys. I'm so sorry I'm not there. I had a family emergency, and I am recording my talk to you today. I will be talking to you guys about what to do when you're diagnosed with leiomyosarcoma, what you need to know, what are the steps that you are going to need to take to be able to advocate for yourself and to be able to take care of yourself. As far as the incidence of leiomyosarcoma, there will be about 2 million cases of cancer in 2024 in the United States, and with soft tissue sarcoma being 1% of those cancers, about 15 to 20% of soft tissue sarcomas are leiomyosarcoma. So in 2024, we expect to have 2,000 to 3,000 cases of leiomyosarcoma diagnosed in the United States. As far as the location is concerned, we know that leiomyosarcomas are smooth muscle sarcomas, and smooth muscle sarcomas can occur anywhere in the body. The most common places are in the retroperitoneum and in the uterus, although it can happen anywhere. We have here you can see leiomyosarcoma of smooth muscle fibers in the stomach or the rest of the GI tract. You can get leiomyosarcoma in the stomach, in the small intestine, the colon, rectum, and then you can get it in the uterus or in the veins that are in the retroperitoneum. Renal vein is one of the common ones that we see. And as far as looking at all the muscles on the body, there are 3 types of muscles on the body. One is the skeletal muscle. Those are the muscles that are voluntary. It will move you. So you voluntarily can move your skeletal muscles to be able to walk. Cardiac muscle is involuntary, but it's on the heart. And smooth muscle are the ones that are spindle shape, and they're involuntary contractions. So the GI tract, you're not able to control the contractions of the smooth muscles. And these are the smooth muscles that can develop into leiomyosarcoma. As far as the staging is concerned, you must know your stage because it does correlate with prognosis. It does correlate with what we can do for you as far as surgery versus radiation. So it's the extent of spread. When they say the patient has stage 1, it means it's localized to that organ. If it's stage 4, it means that it's spread beyond, metastasized to the lungs, which are the most common place for leiomyosarcoma to spread to. The next most common place is liver and then bone. And you should know that leiomyosarcomas can occur in subcutaneous tissue. So a lot of patients come in with a lump on their scalp or a lump on their legs or arms or body, and they're very commonly seen in subcutaneous tissue, which is the tissue underneath the skin. And then also it can extend into the retroperitoneum, so it can go into the kidneys, the adrenal glands, and different parts in the abdomen. As far as the staging here is concerned, we look at the T stage. It's called TNM, which means, okay, the T stage is the size of the tumor. N is if the lymph nodes are involved. And leiomyosarcomas are one of those sarcomas that usually doesn't like to go to the lymph nodes, but again, this is part of our staging system. M means metastasize beyond the organ. And then if you have stage 4, it just means you have metastasis. Stage 3, 2, and 1, they don't have distant metastasis. They could be locally invading the adjacent organs, but not so much spreading beyond the organ. So if somebody comes in with a leiomyosarcoma in their leg and they have spread to the lungs, then that means they have stage 4. It's beyond their original place that the leiomyosarcoma started out from. So this is the stage. And then when we talk about the grade of the tumor, The grade of the tumor is very important as well, because it tells you whether or not chemotherapy is going to work. So we have 3 components that make up the grade. One component is tumor differentiation. Does the tumor look more like the original organ that it started out from? Is there a lot of multiplying, dividing cells, mitotic count? How many cells are dividing and multiplying? Tumor necrosis is how much of the tumor cells, how many tumor cells are dying because they're lacking blood supply, because the tumor is growing fast, it's running out of their blood supply, and then it becomes necrosed. So when you put these 3 components together, they all have different scores. And when you have 3 scores for mitotic count, 3 scores for tumor differentiation, 3 scores for tumor necrosis. And you can see here, grade 1 is basically the tumors that have 2 or 3 of these components. Grade 2 is they have 4 or 5 of these components. Grade 3 is if they have 6 or 7, 8 of these components. Grade 1 are those slow-growing tumors. They're tumors that are not multiplying fast, they're not aggressive, and these grade 1 tumors normally do not respond to chemotherapy. Grade 2 tumors are intermediate tumors. Grade 3 tumors are tumors that are very aggressive under the microscope, and therefore they are fast-growing, and normally these are the tumors that respond to chemotherapy. So grade and stage are very important. Then we go into tumor markers. Tumor markers for leiomyosarcoma are 4 important ones, and these are usually for uterine leiomyosarcomas. The other leiomyosarcomas that are not uterine, they usually do not have estrogen, progesterone, androgen receptors, and they do not respond to hormone blockade therapies. But if you look at the uterine leiomyosarcoma patients who have cancer cells that have receptors on their surface that is expressing estrogen, progesterone, androgen receptors, these are the ones that have a better prognosis for uterine leiomyosarcoma patients. And there are medications, hormone therapy that we can give these patients. And it's important to note that when these cancers become aggressive, they don't usually respond to hormone blockers. So if somebody comes in and has a uterine leiomyosarcoma that is expressing estrogen and progesterone receptors, but they have metastasized to the lungs and they have large tumors, and anastrozole, letrozole, other anti-hormone therapies will not work for those patients. It'll be a waste of time to start patients on these treatments. Also, if the patients have low-grade tumor that have estrogen, progesterone receptors, they actually respond nicely to these anti-hormone blockers. But it's important to note these drugs have their own side effects. You need to make sure that you are checking bone density, because these drugs can cause osteoporosis, can make osteoporosis worse, and they can actually cause osteopenia. They also cause elevated liver enzymes and lipids, cholesterol, triglycerides, as well as glucose, sugar levels. So you have to monitor those very closely. There is another tumor marker which is called a homologous recombination DNA repair system. So this is basically patients who are deficient in this protein respond to PARP inhibitors, and we'll talk about it a little bit later in the talk, that these patients respond better to PARP inhibitors, and that's a very good option for some of the uterine leiomyosarcoma patients. Now, none of this relates to other leiomyosarcoma patients that are not from the uterus. As far as genetic mutations, it is essential that everybody who has a rare disease, everybody who has leiomyosarcoma gets the tumor sample, their tumor sample, tested for genetic mutations. And these are called next generation sequencing, whole exome sequencing. And every sarcoma center, most sarcoma centers have their own testing that can be requested by the sarcoma specialist. They will test for certain genetic mutations to make sure we know what is driving the tumor to grow, and if there is anything that we can give targeting those genetic mutations, then that will be a good option for treatment. For example, the most common markers are these tumor suppressor genes that are supposed to suppress the tumors from growing, but these are genetically abnormal in these tumor cells. So P53 is the most common type that we see in leiomyosarcoma. And then also, I have seen several patients with CDKN2A mutations that we have medications to target. So it's very important to get your report, and in most of these reports they'll tell you what FDA approved drugs are available, targeted agents that are available to block the action of these genetic mutations and therefore stop the growth. We have a lot to learn yet. There are a lot of drugs that came out to block or improve the block the mutational effect of P53, but it didn't pan out so far. So it's important for you to have this genetic mutation on your tumor. Now, there's another test that we need to do is the genetic testing on your own chromosomes, and this is to find whether you have any genetic mutations, hereditary mutations that you could pass along to your children, or that you need to watch out for other cancers. The main important one that leiomyosarcoma can be a part of is Lee-Fraumeni syndrome. Lee-Fraumeni syndrome is when a major tumor suppressor gene in every cell of the body of the patient is deficient. It's not working, it's abnormal. So it doesn't suppress tumor cells from developing. So these are mutations in P53 tumor suppressor gene, and there is an estimation that 500 families have this in the United States, and if one parent has this problem, has this mutation, and the other parent doesn't have it, then the chances of the child getting this is 50%. So if a patient has Lee-Fraumeni syndrome, their children have 50% chance of developing this disease. And worldwide, there's about 1,000 families that have it, and these are multi-generational families, and then it just kind of spreads from there. The most common tumors that are associated with Lee-Fraumeni syndrome are adrenal tumors, breast cancer, central nervous system tumors, osteosarcoma, and soft tissue sarcoma. The most common soft tissue sarcoma that is associated with Lee-Fraumeni is leiomyosarcoma. So everybody who has leiomyosarcoma has to be tested for hereditary genetic testing, because the treatment and the surveillance for them will be different. They would have to be followed they would have to get brain MRIs. They have to get other scans to make sure that they're not developing breast cancer. So this is really important, and they also have to screen their children. There are certain guidelines for these patients to, when they turn 18, to be able to surveil them with MRIs. And it's also important to note that patients with Lee-Fraumeni syndrome are very sensitive to radiation therapy, and they're more prone to getting secondary cancers from radiation therapy. So for most of these patients, young patients who are getting surveillance testing, we do whole body MRIs instead of CT scans to limit the amount of radiation that patients are getting. So again, important to get testing on the tumor, genetic testing, and on your own chromosomes. I cannot stress enough that when you go for your initial appointment with a general oncologist, for you not to take everything in as you're getting told. because general oncologists see about 1 to 5 cases of leiomyosarcoma every year. They're not up to date with the research. They cannot give you the prognosis of your disease. I see so many patients who come to me that said their doctors, their oncologists that they met for a new diagnosis of LMS have told them that they have 6 months to live, and that's definitely not true. So it's very important that you go in there, you're diagnosed with LMS, and you just say, I need a specialist because this is such a rare disease. There's 3,000 cases per year. This is not like breast cancer where there are hundreds of thousands of cases a year. So not every oncologist was familiar with leiomyosarcoma or any kind of sarcoma for that matter. When you're getting referred to a sarcoma program or sarcoma center, you have to make sure that this is a true sarcoma center, that they have medical oncologists who are specializing in sarcomas. They have surgical oncologists that do sarcoma surgeries, radiation oncologists. They have radiologists that are specialized in musculoskeletal radiology reading, and pathologists that are doing, they're seeing pathology from sarcomas every day, not just 1 or 2 a year. It's also important that the program have interventional radiologists, and we'll later talk about ablations and embolizations and those kind of things that sarcoma centers can do now for patients who have leiomyosarcoma. And it's important to make sure that they have clinical trials. Always ask about clinical trials. All of these drugs that we have nowadays or ever have had for sarcomas have all been going through clinical trials and have been tested, and it's important to do that. Now, I want to emphasize something really important is sometimes I see patients who go to 10 different sarcoma centers for an opinion, and that's just too much. The patient gets very confused. Everybody has a different opinion. We don't have huge number of clinical trials to say this is what you need to do, this is what you need to do. Sarcomas are all different. We have 100 different kinds of sarcomas, and just one of them is leiomyosarcoma. So it's important to see a sarcoma specialist. Up to 3 should be maximum sarcoma specialists that you see, and you need to pick one of them to be your quarterback, to be your primary sarcoma specialist. And then you confer with them, and that sarcoma specialist should be willing to send you to other centers if other centers have a clinical trial that they do not have. So they should be willing to work with the other sarcoma centers. That person should be willing to work with your primary care oncologist locally. So say you live 6 hours away from a sarcoma center, you have to have a local oncologist who will be able to give you the chemotherapies that the sarcoma specialist is suggesting. So that's really, really important for your sarcoma specialist to be able to work with your primary oncologist. So make sure that you pick that one sarcoma specialist for your primary and for your quarterback who works with your primary local oncologist and with other sarcoma oncologists. So with your sarcoma appointment with your sarcoma specialist, you need to go in there fresh, meaning that you're not Googling leiomyosarcoma stories. You're not looking at things that are on Google and say, oh, a stage 4 leiomyosarcoma has 6 months to live. That is just certainly not true. So every patient is unique. Your story is unique. You have the sarcoma starts in different places. They spread to different organs. Everybody's different. You cannot generalize LMS prognosis based on stage, grade, or those kind of things. You can say, well, average, it's this way or that way, but you need to be able to find out from your sarcoma specialist what is your prognosis based on what they're seeing on your scans. Patient advocacy groups are extremely important, as you know. The reason for that is they engage you in educational sessions. They bring all of the sarcoma specialists. They give you sessions of education. They give you the data. They show you different treatment options that certain centers do have, other centers don't have. I want to tell you that there are a lot of places that have miracle stories, non-sarcoma clinics. They'll say, come to this clinic. We had one patient who had IV vitamin C and they were cured. And you end up going to those clinics and you pay thousands and thousands of dollars for something that doesn't work. So please make sure you don't get into those situations where you're going to other countries for things that are not proven and things that are not promising. So talk to your oncology sarcoma specialist. See if what you're hearing from those centers makes sense. And ask them about best options for you. Ask them about clinical trials, whether at their center or other centers, sarcoma centers that they know of. So be your own advocate. Make sure you take a family member with you to these appointments, so that sometimes I can talk for hours, but then sometimes patients only take a little tiny bit of the information that I told them, and they don't remember the rest. So it's good to have, be there with a family member. It's important you can even record the session. You can record it on your iPhone and go back to it later on. It's really, really important for you to make sure that you cannot retain everything we tell you in your first visit. As far as treatment options, I wanted to just go briefly over things that are available that I have tried for my leiomyosarcoma patients. Recently, with systemic therapy, we have chemotherapy, we have targeted therapy, we have immunotherapy, which includes T-cell therapy sometimes, and I'll go over that with you in a second. But as far as chemotherapy is concerned, doxorubicin was the first chemotherapy that was ever approved for sarcomas, and certainly leiomyosarcoma. And more recently, the study that compared doxorubicin to doxorubicin plus trabectedin showed some promising results with the doublet treatment. But it's very important to make sure that you're giving doxorubicin and trabectedin, the other name for it is Yondelis, to be able to a patient who can tolerate it. And this combination is mostly for patients who have high volume disease. They have a lot of disease. They're very symptomatic. You want to reduce their tumor burden fast. This was certainly the case with doxorubicin with ifosfamide, doxorubicin with dacarbazine. So doxorubicin can be given by itself. It does have a 20% or so response rate, shrinking the tumor, then some other 20-30% stabilization of disease. When you add it with these other agents, it will give you a faster response and a better response. But it does also carry side effects. So you always have to talk to your oncologist about the side effects. If somebody has few little lung tumors, it doesn't make sense to give them, toxic agents. You can save that for later. Most leiomyosarcoma patients will get all of these drugs at some point during their lifetime if the cancer keeps coming back. So we can save it for later. Dacarbazine usually works better for patients who have uterine leiomyosarcoma, but I've certainly seen it work in patients who have non-uterine leiomyosarcoma. Gemcitabine and docetaxel or taxotere is also another combination that we can give to patients with LMS. And the uterine LMS patients get a regimen where it's day 1 and day 8 every 21 days. But at Stanford, we've been doing every 2-week chemotherapy. They get gemcitabine and taxotere or docetaxel every 2 weeks, and patients can tolerate that much better. And we reviewed our data with Kaiser, retrospectively comparing gemcitabine and docetaxel day 1, day 8 to every 2 weeks, and patients had less side effects with every 2 weeks, and their response rates were similar. But that's a retrospective study. It's not a randomized study, but it's still patients tolerated better. Certain patients can get dacarbazine alone. Temozolomide is a version of dacarbazine that's oral, so that is also sometimes used, and I've had some very good luck with patients who have a slower growing tumor especially uterine leiomyosarcoma. And then trabectedin can be given as by itself as a single agent. And this drug is given over 24 hours, every 21 days, and it's sometimes can have a lot of side effects as far as nausea, vomiting, muscle pain, and those kind of things, but it's usually good, well tolerated, and some patients respond well to this treatment, and they respond for a long time. So I have patients on trabectedin for 2 years, 3 years, and they're doing well, and their cancer responded, and they're living a normal life with good quality of life. So these are the chemotherapy options that we have for leiomyosarcoma at this time. Of course, other agents can be used, but those are special circumstances. Targeted therapy. These are the targeted therapies that I've used and some other sarcoma specialists use, especially pazopanib, which is FDA approved for patients with sarcoma and LMS. And these are the receptors, proteins, that this pazopanib or Votrient actually blocks. Even though it doesn't give you high response rates, but Votrient can be effective in some patients with LMS. It can slow down the growth. It can put the disease into dormant stage. And it's also important to note that not everybody can be on the maximum dose of the drug, which is 4 pills a day, 800 milligrams. So some patients need to be on it on a lower dose, and that's okay, because the diarrhea can be limiting their amount of drug that they can take. Cabozantinib, recently we've used it as a single agent for sarcomas, and there's a study that combined it with immunotherapy, and we've had really good responses with that as well. In LMS, palbociclib, abemaciclib, these are drugs that block CDK4/6 inhibitors. This is exactly why I'm saying that all the LMS patients need to get genetic testing on their tumor, because this is the only way that we will know if your leiomyosarcoma has these mutations, so therefore amplifications, mutations that we can give these oral agents to. And then I have 2 patients with leiomyosarcoma that have NTRK mutations, fusions, and these NTRK fusions have an inhibitor that is FDA approved that can be used for that, and also PARP inhibitors. I've used a lot in uterine leiomyosarcomas, as I discussed, and this again is really important for the genetic testing on the tumor. So these are the targeted therapies that are most commonly used for leiomyosarcoma. And then immunotherapy, traditionally we know that immunotherapy doesn't work as well for LMS. In some patients who have the protein, the PD-L1 overexpression, it can be more effective in those patients. But nowadays we're combining immunotherapy either with targeted therapy like ipilimumab, nivolumab with cabozantinib. We're combining pembrolizumab with doxorubicin in LMS patients. 10 LMS patients on this phase 2 study were treated with Keytruda or pembrolizumab and doxorubicin, and they had a 40% response rate. So there has to be something that immunotherapy is doing, but maybe by itself it may not be as effective as other sarcomas. Sometimes we give immunotherapy with radiation, because radiation can cause tumor death, and then tumor cells will spill into the blood. The dead tumor cells spill in the blood, and then it may make your cancer cells more prone to being killed by immunotherapy. We have done immunotherapy with cryoablation, and in a phase 2 study. So cryoablation, just like radiation, can cause what we call an abscopal effect, which can make the immunotherapy work better. There are some thoughts that LMS can have this B7H3 marker on staining on pathology, which then we can do CAR T cell therapy. This study is now ongoing in Ewing sarcoma patients, pediatric patients, but I've treated one patient with this CAR T cell therapy who had LMS. We had some response, but not long lasting. There's a lot to be learned for leiomyosarcoma and immunotherapy. So hopefully we'll get more in the coming years. As far as local therapy, it's really important for patients to know that if they have metastatic disease, if they have stage 4, we still can treat each tumor with different things. For example, we can do radiation therapy if a tumor is next to the heart and you need your entire lung to be removed for that tumor to be removed. We can do radiation therapy, kill the tumor that's next to the heart so it doesn't cause problems for it invading into the heart or invading into the major blood vessels. Radiation is also important for reducing bone pain from metastasis to the bones. So patients come in with leiomyosarcoma spreading to a femur bone in the leg. Radiation therapy kills the tumor cells, and it also prevents it from breaking as far as or progressing or causing pain. So it really helps with pain reduction of pain. Radiation is also important in some patients who were trying to do surgery, but the surgeon says, can you reduce the tumor size a little bit so the surgery will be easier for the patient and easier for the surgeon, and as well as try to save some of the structures that are around the tumor. So sometimes we do radiation therapy prior to resecting with surgery. Other local therapies like ablation, we can freeze the tumor with cryoablation. Here's a picture of a cryoablation of one of our patients where this is the tumor here, and this is the needle that's in the tumor now, and it's killing the tumor cells with freezing it, and here's the tumor afterwards. Here's another tumor here in the lungs and the abdomen, and then you can see that here's the needle going in and freezing this tumor, just killing this black area is the tumor that's dead, and then afterwards here is most of the tumors necrotic and dead. Microwave ablation is also possible in some areas, and recently we've been using pulsed electric field ablation, which is called galvanized or electrocuting the tumor. So this is better for areas where we cannot necessarily do cryoablation. So for example, if something is close to the intestines, we don't want to do cryoablation because we're going to damage the small intestine. So therefore we can use some pulse electric field ablation. So these are the local therapies that we can also entertain for some tumors that are causing pain or some tumors that are going to cause problems if they continue to grow. Other local therapies, embolization. So for example, if somebody comes in with a liver tumor, leiomyosarcoma, and everything else is stable on chemotherapy, and the liver is an important part of the body, and we cannot live without a liver, so we have to kill these tumors before they grow and cause liver failure. So embolization is basically when you go in to the arteries that are supplying the liver through the groin. You go through those arteries and you squirt either alcohol, we call that bland embolization, where you're blocking off the blood supply, or we can actually put chemotherapy into that part of the liver. And we're just selecting the section where there's tumors. So instead of giving chemotherapy for the entire body, where not all of it ends up in the liver and causes a lot of side effects, we can just squirt the chemotherapy into the liver. The chemotherapies that we normally use is doxorubicin and gemcitabine. The other the thing that we can do with embolization is with yttrium-90, which is a radioactive material that we can put into the arteries that are supplying the tumors and killing the tumor cells with liquid radiation. So these are all liquid stuff that goes directly into the liver. Sometimes we can embolize tumors that are large in the abdomen. We're trying to cut down their blood supply, make them shrink, so make it easier for surgery and prevent it from bleeding during surgery, rupturing, that will be the bland embolization. So these are also options for patients who have liver disease. And so we looked at our data, by the way, for radioembolization, and we found out that patients who have liver disease mainly and not a lot of tumors other places do much better with radioembolization. Instead of somebody who has lung metastasis that's growing, it's sometimes okay to do the liver embolization to save the liver, but we also have to think about what to do with the lung metastasis. Other local therapies, obviously surgery is a local therapy. At initial diagnosis, surgery is the best way that we can cure sarcomas, LMS. Like if somebody comes in with a tumor in the leg, surgery is the best way. Sometimes we do radiation first and then do the surgery to remove the tumor. Sometimes we do immunotherapy and radiation first and then the surgery. But initially when patients are diagnosed, surgery is the best way to cure LMS. At the time of relapse, surgery is still a possibility. But these are for tumors. For example, somebody's getting chemotherapy, all the tumors are shrinking except for one, then that makes sense to do surgery for that growing tumor. If we're doing, if a patient has symptoms, so say if somebody had sarcoma in the retroperitoneum, now the tumor has grown again, and it's not shrinking with chemotherapy, but the surgeon says I can remove this without causing major debilitation, major problems, major morbidity, then we can do the surgery at that time as well. We do a lot of surgeries for recurrent uterine sarcomas, recurrent retroperitoneal sarcomas, and this delays the next relapse. Sometimes we do have a clinical trial with HIPEC. We will have one with PIPEC, and these are basically patients who have intra-abdominal leiomyosarcomas, usually uterine, but other sarcomas, other intra-abdominal leiomyosarcomas as well, is when we take the tumors out, and for the microscopic disease, we put heated chemotherapy inside the abdomen. And by putting heated chemotherapy inside the abdomen, leaving it there for an hour and then washing it out, we hope that some of the microscopic cells will die. And this usually delays the next recurrence. PIPEC is a new method where we're actually pressurizing the chemotherapy into the abdomen with high pressure systems so it can penetrate multiple cancer cells instead of just one or two cells. So that's another way that we can help the surgery work better and then delaying the recurrences. So as far as concluding, please, when you are diagnosed, I know that a lot of my patients have post-traumatic stress disorder from the primary oncologist telling them that they have a few months to live. Please just try to get those things out of your mind. See a sarcoma specialist. Do not get too many sarcoma opinions, because that kind of confuses everything, and then you're just left with this person said something, the other person said something else. Pick your oncologist, sarcoma oncologist, that's willing to work with you. On your first visit, ask about clinical trials. On every visit, ask about clinical trials. Meet with the sarcoma surgeon early on. So if we're doing chemotherapy to shrink your tumor so that you can have surgery, meet with the surgeon while you're doing the chemotherapy. So at least you get to be comfortable with your surgeon. Ask about local therapies. If you have a tumor all of a sudden growing in your lung that's small, instead of doing multiple surgeries after surgeries for lung metastasis, we can do cryoablation, microwave ablation, radiation. So ask about local therapies for things. Instead of getting high doses of, massive doses of chemotherapy for little tiny disease, you may be able to locally treat that disease. Participate in educational events for LMS. Do not go into Google. Do not look at patient stories. Your story is unique. You're not like everybody else. You need to be your own advocate. You need to reduce your stress level. I know it's hard. Patients are diagnosed with a cancer. It's easy for us to say, reduce your stress, but meet with a psychiatrist, meet with a therapist. Try to see if there are any medications you can take to reduce your stress level. Ask about what diets are good for you. We know that plant-based diet reduces inflammation in the body. We know that that improves the immune system. We know that not in sarcomas yet, but we have data to prove that patients who are on plant-based diet have delayed in their recurrences, or maybe not even get a recurrence of their cancer. And these are usually in colon cancer and breast cancer, because there are too many patients with those diseases, and they have a lot of studies that they have conducted in those patients. So that's also very important. And don't if your therapist says you need to take an anti-anxiety medication, you take it, because that's going to improve your outcome. I received some questions from you guys, so I'm just going to touch on those really quickly. So we talked about surgery versus chemotherapy. It depends whether surgery can be done. If you do chemotherapy, everything is stable. If a surgeon can remove the tumors, that's the best to do, because chemotherapy will not get rid of the entire tumor in most situations. One question was, why is Natera circulating tumor DNA assay not picking up small lung nodules? That's what we've noticed in LMS. Smaller lung nodules are not, they don't shed in the blood, so we don't pick them up. Stanford and other places are trying to get more accurate blood tests, but for now, Signatera has to be used with scans. You don't want to just do Signatera testing and just not do any scans, so it goes hand in hand together. One other question was, how do you get a second opinion for sarcoma? It depends on which state the sarcoma oncologist has license. During COVID, we could do video visits all the way to New York, but now we have to have a license for that state to do video visits. There is a sarcoma second opinion online for Stanford, and I'm sure other places have it too. So that also is available online, where you would actually submit your documents, your scans and everything in the pathology, and then we give an opinion online for you guys. But if for me in particular, I can do second opinions by video in the state of Washington and state of Nevada and California, and hopefully in Oregon soon. One other question was, how long can LMS remain dormant? LMS can remain dormant for decades, and I've seen patients recur 10 years, 11 years later. So it's really important for you to continue your monitoring, continue to see a sarcoma specialist, do your scans, and listen to your body. So that can get those late relapses, although late relapses are rare, but they still happen. And the LMS research at Stanford, we are very dedicated to HIPEC and PIPEC surgery for uterine leiomyosarcomas, but we're also opening several industry studies for leiomyosarcoma soon to be opened. The Polaris study is one that we're very much interested in. That's Dr. Van Tyne's study, so we'll hopefully be opening that study soon. So I think I'm over time, and I wanted to thank everybody for coming to the LMS meeting. I'm even wearing my LMS earrings, which I love, and I hope you all have a good meeting and become very educated and become yourself advocates. And I'm happy to answer any questions later. You can email me and we can go. I can answer you through email. Thank you guys. Bye-bye.